Good evening, everyone, and thank you for joining us on this very hot, warm day. It's nice to have you with us for our first webinar. This webinar will be available to watch as we're recording it, and it will be on our YouTube channel, the Sussex Group. There is one CET point for today's lecture. That's if you're watching live and have joined via the registration on your email. And the CET point is available for optometrists and dispensing opticians. The lecture will run for approximately 45 minutes and with questions at the end. On the bottom of your screen, there is a Q&A box. And if you have any questions throughout the lecture, if you type in there, and we will aim to get through as many questions as we can at the end. So today's speaker is S Kashani. Shah is an ophthalmic consultant surgeon at East Sussex Healthcare Trust, specialising in the management of complex medical retinal disorders. He performs intravitreal anti-VEGF injections, steroid implants, anterior and posterior laser treatment, as well as high volume cataract surgeries. So thank you very much, Shah, and I'll pass over to yourself.
Thank you, Ian. Just to say before we start, somebody in the Q&A is asking to repeat the website, I think you said, the website address. But anyway, I don't know if you can answer that through your Q&A. I'm going to share my screen now. And hopefully that should be it. Right, thank you very much for coming on today. I realize it's an amazingly hot day and everything is good. When I started this together with Ian and Cash, the idea initially was obviously to get some conversation going through WhatsApp with respect to various policies, questions you may have during COVID, but actually it's proven to be quite useful. I hope you'd agree. But really the main crux of it was to have monthly webinars, and these would be all CET approved. We'll have various speakers coming in covering various subjects. So hoping certainly to do one a month, which I think would be an achievable aim. And then, you know, the case kind of cases that we post on the WhatsApp group, probably going at the moment 2 a week, but as you all get busy, we might reduce that to 1, but we'll see how we go with that. But certainly the webinars will be once a month, and the chat will carry on the WhatsApp group as before. So, okay. Here are my contact details. So most of you know who I am anyway. That's my email at nhs.net. If you have any questions, please don't hesitate to contact me. Website for any kind of advice or things you may need is also there. I don't know if you guys do Twitter and Instagram. Occasionally, apart from awful TikTok videos, I do actually post some interesting OCTs or cases, although I must say with current COVID, that's lagged a bit, but as we come out of COVID and patients are coming in, there should be more on the Instagram. Okay, so really the aim is to know what common symptoms may present patients who have retinal disorders, what you might find commonly on examining patients, who you really need to refer, and that's quite important nowadays, especially as you're not opening up yet and you're kind of thinking who you should be really seeing or not. Timescale for referrals, I think that's quite important. What's urgent, what's not urgent, and you know, still taking into account COVID crisis. I mean, we're by no means out of this. We're still going to have social distancing. Numbers coming in are going to be slow, very slow in clinics when we are recovering. So it's going to take some time before we go to normal. And I think the landscape is going to change permanently for certain things. And I hope this talk at least raises awareness on what cases you really need to worry about and when you don't. So when it comes to symptoms, and we always thought that actually that's one of the most important things, and you may have a lot of patients who may call you up and say, do I need to be seen? Do I not need to be seen? One of the first things you need to ask is symptoms. And all these symptoms are very important. So central vision loss, distortion or gaps in central vision, loss of color vision, peripheral shadows, flashing floaters, positive scotoma, pain and redness, and gradual loss of vision or night vision issues or color vision. Now, a lot of these symptoms you would then go on to explore and find out how long they've had it or how severe it is. Generally, you know, by now, I'm sure most of you, are, if not all of you, are very experienced in knowing when you worry about pain and redness and when you don't. So for example, you know, somebody with conjunctivitis might have a little bit of pain and a little bit of redness, but wouldn't stop them doing what they're normally doing. And somebody with scleritis will tell you that they cannot look at light and they sit in the room and, you know, nothing takes the pain away. It's literally the worst pain they've ever had. So, you know, you need to put all those symptoms into context, but generally, any sudden loss of central vision or peripheral vision needs review. I always get asked about flashing lights and floaters. And again, my answer would be that if it's sudden onset and the patient's called you, then that needs looking at. Again, that situation is very different. Somebody who said, oh, I've had floaters for months and it's still the same, than somebody who says, I have an acute floater. So you need to take that into consideration. Now, before going on to this talk, I think anatomy, well, it certainly always helped me to look at anatomy. And one of the things that I would like to impress on you during this talk, that actually when you look at an OCT, it's very different to when you look at the cell lines within the retina. So the retina has 4 major cell from the choroid by a very thin membrane. Then you have the photoreceptors. You then have the bipolar cells, and you also then have ganglion cilia at the top. And you may then see all these other kind of lines up here, and that tells you that these the various layers that you might see on the OCT. So the layers that you will see on the OCT is different to what you may see on histologically when you look at the retina. And again, this goes on to show you that very important fact that you're looking at an OCT here, and there are lots of different various structures that are written on the OCT, and it's worthwhile having a look at these because they are important when it comes to looking at patients and where the pathology might come from, but realizing actually all these 10 layers represent 4 cell lines, which I described earlier. Okay, so the first case then is a case of a 73-year-old man and says he can't see far or near. So I'd be worried about that because it's sudden onset of loss of central vision. He basically states that this is fairly sudden, it's mainly in the right eye, everything seems distorted. So central loss of vision and distortion are 2 things that one should definitely worry about. And that's the color fundus picture. Now, normally if we were all in a screen, I'll be asking you to tell me what's going on and name what's happening. And here you can hopefully see a central macular hemorrhage. So the question is, what is causing the problem? And the commonest cause for this would of course be wet macular degeneration. So this would be the result. So there's central loss of vision, so they can't see anything in the middle. You can have peripheral vision, which is normal with this, but the central vision is gone. And this is what we used to do in the past, which is to do fluorescein angiography in order to see where the membrane is coming from and where you can see the wet AMD. But you know, we hardly do that now. We don't really do fluorescein angiography now. In fact, I can't remember last time I did fluorescein angiography for a patient with wet AMD. Now we just go on the OCT. And the main thing is really with wet AMD, you don't have time. You have about 2 weeks to get this patient an injection. And even then, sometimes that can be too late. I've seen patients present 6/18. By the time they've come to us 2 weeks, they've gone down to 6/24. And that depends on how aggressive the wet AMD is. So realistically, we do want to treat these patients sooner than later. The only cases I suppose that I would do fluorescein angiography on is if the patient is diabetic and the OCT is borderline. And the reason for that, I think, is the prognosis is different if you've got diabetic retinopathy or wet AMD. And I think in that circumstance, it's important to establish diagnosis. But sometimes if I think I'm not going to get the fluorescein like we are not now, you might actually treat the patient anyway and then come back to it. So wet AMD then, always urgent. You must refer within 2 weeks, and there are very clear pathways. Please do not refer these patients to your GP, to the GP to come that way. There is a dedicated email that we have for Eastbourne and Conquest, and these patients should be sent, query wet AMD. There's a Royal College has a specific proforma that you can fill out. If you don't have access to it, just refer the patient. It's important to know the vision, and actually, irrespective of what the vision is, if there is wet AMD, refer. I know at the moment NICE stipulates that we can only treat if the vision is between 6/12 and 4/96. But if you've got a patient who has query wet AMD and the vision is better, or even worse, you should refer that patient. And I said, as I said, wet AMD, everybody thinks super aggressive, but I've seen cases of wet AMD which has been very aggressive within a week. And I've seen cases of wet AMD which has taken months and the vision just slowly declines. I've written here, classic membranes do worse. And we don't really classify them into classics and occult anymore. This was a previous angiographic classification, which we used to use because they used to use PDT laser to treat this. But now with anti-VEGF therapy, it doesn't really matter what type the membrane is. Classic membrane, for those who want to know, just lights up much quicker on an angiogram, and on occult, it doesn't. So main aim with this, refer that day. Okay, so case number 2, 24-year-old female, type 1 diabetic for 10 years. So one of the things that you should always ask patients if they complain of floaters or flies in the vision, ask if they're diabetic. In particular, if they are diabetic, you may then want to ask when the last screening test was, if they've had any laser treatment, stuff like that, to try and understand how bad it is. So diabetic screening service would write to the patients and say, your diabetes is not that badly controlled, or you come back in a year. But certain patients would be under hospitalized service, and normally if you're anything more than background, you'd be under the hospitalized service. So it's always important to establish how bad their condition is. So in a diabetic, this is what you see in the back of the eye. So again, hopefully you'd be worried about this. This patient has had a massive hemorrhage. If you look, you will be able to see some retinal hemorrhages there, but this is a very large pre-retinal bleed. Now, again, if some of you were sitting in front of me, I'll be asking you, how do you know where the hemorrhage is? Is it under the retina? Is it on top of the retina? Is it within the retina? And the answer is, you look to see blood vessels. So if it covers your retina and it covers the blood vessels, then it must be sitting superficially or on top. And this is something you get when new vessels bleed. Now, new vessels are always more significant when on the disc. New vessels are less significant when they're on the peripheral retina, but we still treat new vessels elsewhere or not on the disc. And treatment is done with urgent laser treatment in order to kill off the stimulus for this. So the reason you get abnormal blood vessels in diabetic retinopathy is because diabetes causes very hypoxic condition within the retina. Retina releases vascular endothelial growth factor, otherwise known as VEGF. VEGF makes blood vessels leaky, hence you get macular edema. And that's why anti-VEGF works, because you block that VEGF signal. But as VEGF carries on and on and on, you get these abnormal blood vessels, which grow from the venous side of things. So new vessels always grow from the veins, not the arteries. And then when these blood vessels bleed, it becomes a nightmare, because then you can't see the back of the eye to laser them. And that's why we have a very strict screening service to pick up these patients before this happens. So this is what you might see or not see, as it were, a very blurred view. You can just about see the disc, but nothing else. And at this point, there's very little you can do about the patient. We would refer this patient for a vitrectomy. By the time they get there, if enough blood has resolved, they might do a bit of laser treatment if they can and avoid vitrectomy, but often in type 1s in particular, they'd have to go in and remove the vitreous and deliver laser therapy then. So this is what you wanted not to get to. And sometimes you see patients with really aggressive proliferative retinopathy, we treat them there and then in clinic to avoid this. So the aim of laser treatment, peripheral laser treatment, is that you kill off the photoreceptors, and that will stop the VEGF drive. And that way the new vessels will regress. There is new evidence, although this treatment is not currently available on NHS, hopefully it will, that anti-VEGF therapy for proliferative disease is also very useful because it gets rid of your blood vessels. At the moment, anti-VEGF is only used to treat the macular edema, but I've got a couple of patients who have anti-VEGF to minimize peripheral laser treatment, and hopefully NICE will approve that so patient can have that treatment on the National Health. Okay, so proliferative diabetic retinopathy, if there's vitreous hemorrhage or if there's proliferative changes, I would refer urgently, please. We need to see these patients straight away. We would want to laser within a week. Now, sometimes if the patient comes with proliferative disease and significant macular edema, where we can treat with anti-VEGF, so central retinal thickness, that's the smallest circle on the OCT of more than 400 microns, we'll start with anti-VEGF therapy. And there is evidence from the DRCA trials to show that actually if you started with anti-VEGF therapy and delayed the laser, that will be fine, because the anti-VEGF will treat macular edema and the blood vessels, and then you can deliver the laser treatment later. We always treat laser, we do PRP because it's another bleed, the blood will settle down and then we can't see inferiorly. So we always treat that and then go to the top. I tend to do it in two sessions or 3 sessions rather than 1, because that will minimize risk of macular edema. If you do all of the retina at once, you are at risk of getting macular edema. And if there's no view, we often do an ultrasound scan to make sure the retina is not detached. Don't always assume that in a diabetic is going to be proliferative diabetic retinopathy, especially if they have background retinopathy. They might have a retinal tear and then they have a detachment, and you're kind of missing the boat there. So there is a need to do an ultrasound scan to make sure that the retina is not detached if you can't see the fundus. What you don't want is this. So advanced diabetic eye disease, these patients have no vision, NPL vision, but the problem is not only they have very poor vision, they also cannot see, sorry, they also have a very painful eye. So this is neovascular glaucoma, pressure goes up, and sometimes, pressure can be 40 and 50, patient's not aware, vision is PL or NPL, but actually as the pressure keeps creeping up, the cornea can become oedematous, and that's when the pain can set in. So often patients who've got corneal decompensation with neovascular glaucoma, we use steroid eye drops and atropine in order to manage the situation. And this is what you want to see. So laser treatment to peripheral part of the retina. I mean, this patient hasn't had very intense laser treatment, so you could come in a little bit more, but you kind of deal with that as far as the eye needs it or can take it. Don't forget, the more laser treatment you do in the periphery, the more peripheral vision they lose. So one of the things you must warn these patients, and often they're young, type 1 drivers, that they may not be able to drive. And that's sometimes a very hard sell, because you can have patients with proliferative diabetic retinopathy and 6/6 vision. And you're going to tell them that you might then intervene and do something to them when they don't have any symptoms, and that could stop them driving. So it can sometimes be quite a difficult conversation, but most of them thankfully go for the treatment. One particular group that do progress quite badly with proliferative disease are pregnant patients and those with renal failure. The other issues are chronicity of the diabetes, type 1 patients, and those who are poorly controlled, not just diabetes, but hypertension as well. So treating the hypertension, the diabetes, all these things are very important in preventing the eye disease. Diabetic macular edema, so I sometimes get referrals for urgent. It's not urgent. If you think about the screen, as long as that's what you think it is. So if you've done the OCT, you're fairly confident it's not wet AMD. You tend to see exudating diabetic retinopathy rather than wet AMD, although you can see exudations in wet AMD as well. But if the person's diabetic and it looks like DMO, sure, you can send the referral in and we'll do a scan and see how bad things are, but it's not often urgent. So if you think about referral time from diabetic retinopathy screening service to hospitalized service, we have 13 weeks to see these patients. Now compare that to wet AMD, where it needs to be done within 2 weeks. And this is kind of me trying to simulate what you might see with DMO, a bit of distortion in the center, but nowhere as bad as what you might see in patients with wet AMD. Okay, so message there is in a patient with diabetes, if you see abnormal vessels on the disc or elsewhere, that's an urgent referral, in particular if there's vitreous hemorrhage. Now, case 3 is a hypertensive patient, sudden onset of floaters for a few days, good vision, no RAPD, and good red reflex. RAPD is quite important because its presence is always abnormal, and often it indicates problem with the optic nerve on one side. But if you've got 75% or more of your retina involved for whatever reason, then you can have RAPD with that as well. So this is the clinical picture. You can see a pale lesion there. You can see vitreous hemorrhage. So that's vitreous hemorrhage. You can see pre-retinal hemorrhage there. And then you can see deep retinal hemorrhage there. Now, how do I know that's deep? Well, you can see a blood vessel going over it. So you know this patient has bled and the bleeding has gone underneath the retina, within the retina, and into the vitreous. And this kind of pattern is very typical of 3 conditions. One is a condition called a macroaneurysm. And macroaneurysm, but on a blood vessel that's a lot bigger. So a microaneurysm you will see in diabetes when you've got dilation of the capillaries. Macroaneurysm will happen in an arteriole within the first divisions, 3 divisions, sorry. And when a macro bleeds, you can get this multi-layer hemorrhage. Another condition, 2 conditions you can get this, and they're both actually variants of AMD, is IPCV. So that's idiopathic polypoidal choroidal vasculopathy. And the third one is if you have wet AMD with an RPE rip, that can cause kind of massive hemorrhage like this. So with this patient, what you can see is if you follow the arteriole there, you can see around about here, there is a lesion there, and then it carries on. So this is a patient who has a macroaneurysm. And this is another kind of picture with fluorescein angiography showing you kind of hemorrhage that's very superficial, hemorrhage that's deep because you can see blood vessels over it, and vitreous hemorrhage. So with macroaneurysm, you can refer. We don't need to often see it urgently because, to be honest, what we often do is we need to decide whether we need to laser this patient or not. The decision to laser, and I've done a few lasers for these patients, is whether the macula is threatened. Because often what happens is that the macro bleeds and then the bleeding resorbs and things go back to normal. But if the macro continues to bleed, or if there is exudation and fluid which is going to go down towards the macula fovea, then you might have to treat the macro. And the way you do that is you laser carefully around the macro, and then you need to change the laser setting and just burn the top part of the macro so that you kind of thrombose the macro. And that way you will kind of stop it. The issue sometimes is that you might then cause an arterial occlusion downstream if you're not careful. So that is a risk, but you know, it's a risk that in some cases you might need to take. Especially if the macula is threatened or if the hemorrhage is not stopping. So the hemorrhage can take a few weeks to settle. You need to check blood pressure. One thing I would say actually is carotid Dopplers in patients who have multiple macros, and sometimes patients who are throwing off clots from the neck can cause multiple macros. So that's an important thing to look out for. So a message with macro is, it can look pretty scary. You'd often know it's not wet AMD because often the initial area is obviously coming from a blood vessel, so that's not going to be macula, it'd be further up or inferior. But obviously, you know, if it's looking like that, then a referral needs to be made, and we will look at the patient within a couple of weeks. Now, this is a picture of a patient who quite unfortunately had really bad advanced testicular cancer. But anyway, that's not why he came. He came because he was straining, the morphine had given him constipation, he was straining, and then suddenly he had sudden loss of vision. So what you can see here is multiple areas of hemorrhage. And what I'd like you to appreciate is this, what you can see, a fluid level. So you tend to see this when the vitreous is very adherent to the retina. And if you get something called valsalva retinopathy, which is when you are coughing quite a lot, or if you're in the gym and going a bit hard at the weights and you burst superficial retinal vessels, you get bleeding. And then the bleeding will not go into the jelly because the jelly is still quite tough. So the bleeding stops between the jelly and the retina, and you get this fluid level there. So this is pre-retinal hemorrhage, and this patient has valsalva retinopathy. Most of the time it goes away, but you cannot afford to leave that hemorrhage there for a long time. So if you are sure that's what it is, we can YAG the inferior base and allow the hemorrhage to be released from the front surface of the retina into the vitreous. So you'll induce a vitreous hemorrhage. And by doing that, you will stop the blood sitting next to the fovea and causing toxic issue with the iron and the photoreceptors. Next case is a 22-year-old man, 3-day history of flutters and flashing lights, fairly constant, but he got worried as there was a shadow. So hopefully most of you will want to see this patient straight away. There's a visual field defect as well. I think some of you have seen this picture actually on the WhatsApp group. I've sent it before. And this clearly shows retinal detachment. So this is another retinal emergency. You all know how to deal with this. It needs to go, it needs to be referred straight away. So when you see like this, you can actually refer them direct to Brighton if you're sure that there is retinal detachment. If you see a tear without subretinal fluid or without retinal detachment, you should refer to us because we could do laser retinopexy. But if you see clear retinal detachment, it's a tertiary sensory referral straight up to Brighton. And if the macula is on, it's very important to mention that. So vision is often very important. Once the macula comes off, the prognosis goes down significantly. Normally, they would operate on these the next day if the macula is on. If the macula has just come off, i.e. the vision is dropped and it's within a few days, again, they will try and take the patient in and operate straight away. Chronic retinal detachment will end up waiting for months. Vision won't return really, but the reason you need to fix the retina in somebody who's had chronic retinal detachment for months and months is that if you don't, the retina will become ischemic and you'll develop new vascular glaucoma. So urgent if macula is on, or if the macula is just off, and I would say just within a few days or a week, refer the same day. There you go, I've actually mentioned the macula off thing there. Chronic MAC-off retinal detachment needs attention, but not urgent. So I guess the issue is, you know, sometimes you can look at the retinal detachment and know, if some of you were on the WhatsApp group, I'd mentioned different features of regmatogenous versus serous versus tractional RD. So there are certain features within retinal detachment which makes you think this has been there for a long time. But if you're not sure about the history, refer urgent. Next case, 72-year-old patient, injection with Eylea for diabetic macular edema. This is everyone's nightmare. Sudden onset of pain, redness after 3 days. So you should never, ever not see a patient. So I'm saying that really badly. You should always see a patient if they call you up and say, look, I've got redness and pain and the injection has been done within the last 2 weeks. And that's because you cannot exclude endophthalmitis unless you see it. So usually the onset of pain with endophthalmitis, kind of giving the game away here, is from day 2 right up to 2 weeks. It doesn't mean it can't happen after 2 weeks, but it becomes a lot less likely. And you can easily distinguish the pain and the redness that you might get with a bit of dry eye from endophthalmitis. But normally, and I do a lot of injections, pain on the day as soon as they get home, or the next day if the eye is irritable or painful, it tends to be either a small abrasion or the eye is just sore and streaming. Really, by day 2, it should almost be gone. So if they call up and go, oh, you know, I've had an injection yesterday, the eye is a bit painful, but I can kind of see things that are a bit blurred, you can wait till the next day. But if by the next day they say, oh no, you know, things are not good, then you need to be seen. So if in doubt, see them on the day. But as I said, pain on the day and, you know, day 1 after the injection is very unlikely to be endophthalmitis. Always have a very low threshold for seeing these patients though, because every second counts with endophthalmitis patients. So if you're, you know, if they call you day 1 and you think, oh, you know, the pain is quite intense. You know, the night before they didn't have pain, but this morning it started, and the vision's like really blurry. So what you're looking for is to see if there is any progression of symptoms. So pain, redness, vision loss, all those things. So if they got home, vision was quite clear, and then the next day they woke up and the eye was getting painful and the vision was quite blurry, I would see that. But normally with endophthalmitis, these symptoms tend to occur from day 2 onwards. And it's increasing pain, redness, and inflammation. You don't always get the hypopyon. I've seen plenty of endophthalmitis within, you know, where there is no hypopyon. So don't look for that, but you should be able to see AC activity. And as I said, if we have any doubt at all, the patient goes in, they have vitreous removed and antibiotics injected straight in. What we normally do, send the vitreous tap. You can or may not do an AC tap. You fill the eye up with antibiotics and then look again 48 hours. And if after 48 hours it's not better, you may repeat that. If it's still not better, 48 hours after that, you might need vitrectomy. So any sort of intraocular surgery, in particular injections, tend to be more with injections than cataract surgery. You've got increasing pain, increasing redness, photosensitivity, decreased vision, anything like that, see the patient. So I just want to clarify that that day, I tend not to worry about bit of pain and redness and watery eye. The next day, I would expect that to be better. So if on the night they were fine and then they wake up and the next day they're getting worse, then you need to see the patient. And often with true endophthalmitis, bacterial endophthalmitis, the vision prognosis is very poor. What we tend to get a lot is what we think is bacterial endophthalmitis, and it tends to be toxic anterior shock syndrome. So in fact, they've just massively reacted to the drug or the needle going in or something within the drug. And they tend to do a lot better because you do the tap, nothing grows, put the injections in, which wouldn't make a difference, treat them with steroids, and the vision returns. So although true bacterial endophthalmitis may not yield a bug, often the ones who do really well probably didn't have bacterial endophthalmitis. They probably just had a severe uveitic reaction to the injection rather than anything else. Okay, enough of that. So another emergency. Next case, 70-year-old, type 2 diabetic hypertension, sudden loss of vision, constant paleness, and there is an RAPD. So there's something wrong here. Hopefully you will all know that this looks like a very hemorrhagic fundus, loads of cotton wool spots, and this patient has a central retinal vein occlusion. It's central because the whole fundus is affected with hemorrhage. It's often important to distinguish whether they're ischemic or not for prognostic reasons. So ischemic CRVO tends to have very poor vision, counting fingers or below. They'll have an RAPD. They'll have very hemorrhagic looking fundus like this picture shows, and they don't do well. Non-ischemic, vision's good. Hemorrhages are less deep and less florid, and there's no RAPD. But it's important to realize that actually 1/3 of your patients with non-ischemic CRVO will become ischemic. And that's irrespective of anti-VEGF therapy. Anti-VEGF therapy purely treats the macular edema. It does nothing to stop an eye becoming ischemic or not. So that's often something to mention because occasionally, you know, you're down to your 4th or 5th injection, and then the patient comes back after the injection and they lose vision because they've gone ischemic and they think it's an injection. It's just unfortunately 30% of the non-ischemic eyes will do poorly irrespective of what you do. But branch retinal vein always has a better prognosis. But one thing that we always do with patients is that we ask for a full blood count, ESR, HbA1c to exclude diabetes and blood pressure. If there are any unusual features, then you might ask for more things. For example, somebody who has vein occlusion if they're under 50, somebody who has vein occlusion in both eyes, somebody who might have systemic condition that would go with the vein occlusion. So anything like that, then we would ask for you know, clotting screen or whatever that would be relevant. But that would be the basic kind of test that we would do for vein occlusion. So this, I hope you appreciate, is a branch retinal vein occlusion. So you can see hemorrhage there, you can see exudation, you can see macular edema. These patients, again, need anti-VEGF therapy. They tend to do better, less tend to be ischemic. These patients need treatment with Eylea, Lucentis, or Ozurdex as well. We use steroid in patients who are pseudophakic, patients who tend to not want to come to hospital quite a lot, patients who don't have risk of cerebrovascular accidents or heart attacks. So Ozurdex tends to work better for them. But a lot of diabetics, if they're obviously the young phakic, they tend to have anti-VEGF therapy. Right, so next on, 45-year-old man, ischemic heart disease, atrial fibrillation, lupus, sudden onset of complete loss of vision, another patient with relative apparent pupillary defect. And that's what you see. So it's a very classic picture of central retinal artery occlusion. You can see very attenuated arterial vessels, and this, I'm sure most of you would recognize, would be the cherry red spot. Now, the cherry red spot doesn't last forever. It's present probably for 24 hours to 48 hours, not significantly more than that. And it's present because what happens when you get a central retinal artery occlusion, you get edema of the retina. And in the fovea, if you've looked at enough OCTs, you can see that there is a dip. So you can see the red spot is the choroidal blood basically coming through in context of a very oedematous and white retina around. So this patient has a CRAO, and that's an urgent referral because it's, in essence, having a stroke. We refer to rapid access TIA team, who will then do ECGs, echo, Dopplers, imaging, bloods, etc. Big things that we want to exclude if the patient comes middle of the night is a quick ESR and CRP to make sure he's not GCA. They would have headaches and symptoms like that, but I would, want to do that to make sure that it's not an occult GCA as well. But really, the reason for referring to TIA team is to make sure that they're not having fast atrial fibrillation, or they're not throwing off clots from their heart or their carotids, because if the next one goes to the brain, then that will be a full-on stroke. This is a very nice picture of a branch retinal artery occlusion. So you can see the white fluff, and that's edema. Okay, so edema is white, and then that will settle back down. So if you see a CRAO or a BRAO, you just see atrophy of the retina, mostly picked up on OCT scan, actually. So you see a patient with segmental atrophy on OCT, think they've had a previous arterial or venous occlusion, and you can see a clot there in the artery causing a BRAO. Once you get the visual field loss, it doesn't come back. So CRAO, vision won't come back. BRAO, you'll have a visual field defect for life. Now, so another condition that you probably wouldn't want to sleep on would be uveitis. So this kind of patient, they will have pain, photophobia, redness, vision loss, floaters, sometimes associated symptoms. Referral for uveitis is urgent, whether it's anterior posterior. Anterior uveitis, if not seen, can become really nasty. They can have 360-degree synechia, pressure can go up, vision can come down. And when there is posterior segment involvement, the prognosis is often much worse, in particular if the disc is involved, there's retinitis, vitritis, etc. Now, I'm not going to really talk much about uveitis because I think that's the next topic that will be discussed next month in the webinar. So I'm not going to mention much about that. But in essence, the principles are, when they come to clinic, do you have time to investigate? Do I need to start oral immunosuppression now? Do I need antibiotic, antiviral cover? Is this ocular systemic? Those are the kind of 4 things that goes through my mind when I see patients with uveitis. From your point of view, if you've seen patients with anterior uveitis or vitritis, please refer them straight away. And this is why these kind of patients will not be gaining any sight back. And as I said, I'm going to leave that to Cash, who will discuss that with you at the next webinar. Coming to an end now, I think I've got 5 minutes. Case 8 is a 55-year-old female, flashing flashes in vision, blurring of vision. Vision is 615. This is what you see, a very large pigmented lesion in the back of the eye. And this is what would show up as, hopefully you will agree, as ocular melanoma. So what would make you think if it's ocular melanoma? Sorry, let me just. What would make you think that this is ocular melanoma is that you look at this mnemonic, TFSOM. So you look at thickness, presence of fluid, symptoms, orange pigment, and margin, which is touching around the optic disc. So with thickness, if we say it's more than 2 millimeters, obviously that's going to be an ultrasound diagnosis, but good going ocular melanoma, you don't need one of those, you can see it. Fluid, if you can get the OCT over it, it'd be great. If it's obviously macular central, you know, don't forget your OCT will go to the front 6 millimeter by 6 millimeter. If it's a bit more peripheral, you might not be able to, but if there's subretinal fluid, that's bad news. Symptoms, so this lady has flashes, or if they have flashes or they see a shadow, that's important. Orange pigment, or we call lipofuscin, is important marker. And then of course, how close it is to the disc. And this needs a referral within 2 weeks as per cancer guidance. Things that are not so urgent, some of you might get surprised by this. Macular hole, of course, we need to know. A lot of the times I get referred for query wet AMD, especially if there's no scan available, and then you look and there's a macular hole. I don't see these patients in clinic, I just refer them direct to Brighton. You can see a full thickness macular hole here. At the bottom here, you can see vitreomacular traction. Again, these are not urgent. I'm not saying don't refer them, of course refer them, but we would get the scan to confirm diagnosis and then send them to tertiary center for the macular hole. VMT you can watch, but if the distortion is significant or it's getting worse anatomically, then the option would be vitrectomy. Ocroplasmin was a drug that was favored a few years ago, but I don't think many people are using it. It's expensive, and we now know it can cause some serious side effects within the eye. So I send them for vitrectomy if I think the vitreomacular traction is significant. And finally, you can see an epiretinal membrane here. Again, not urgent at all. I would either refer them on to a tertiary center if they need surgery, or to be honest, discharge them. So to good selves. So any of you who have an OCT, you'll be able to monitor this as long as they don't have distortion with both eyes open, or anatomically the ERM is not getting worse, you could probably observe this in the community. Now, this is a patient. I'm going to tell you what the diagnosis is, because I'm not sure if I've shown it to you guys, but this patient came to me in Eastbourne. She was a 43-year-old lady who was, I think her BMI was around 37 or 38, so high BMI, and she had pancreatitis, and she presented with blurred vision. So if any of you would care to write what you think this is, I'll be very impressed. It's quite an unusual condition. Anyway, I think that's it. Thank you very much. I'm going to stop sharing now. So Ian, do you want to come in?
Hi, Shah. Thank you very much for that. That was really interesting as always.
I kind of slowed down a little bit because my computer said unstable internet, and then that threw me off completely.
And then
because I thought, oh God, I couldn't see if my Wi-Fi was on. Sorry?
And you've got a software update message as well.
Yeah, but it wasn't interrupted, was it? You heard of it.
No.
Okay, fine. Okay.
So, but thank you very much for that, Shah. That's fantastic. We've got a couple of questions, if that's okay.
Yep.
If we've got a few minutes to go through these. So the first question is, would you ever recommend vitrectomy for non-diabetic, long-standing patient with very symptomatic floaters?
Okay, so that's a good question. So floaters are often quite annoying to patients, and vitrectomy for floaters or laser floatrectomy are two options that you can consider. Now, both are not without risks, and I know my colleague Cash does a few of these laser floatrectomies, so he would probably be a better person to answer that question in due course. But I'm aware of the indication. So if the floater is significant and is really bugging the patient, and if the floater has certain characteristics, like you can clearly see it, it's away from the retina, back of the eye, you might be able to laser that off, and you can laser it off into lots of little pieces, and that might be less problematic to the patient. But you really do need to counsel the patient very carefully. With respect to vitrectomy, you want to ensure that the vision's down. So you want vision of 6/12 and below. You need to ensure that the floaters are really causing problems, is stopping them doing what they normally like to do. And again, these patients will have an 8% risk of a retinal tear, which will need more laser treatment. If they then have a vitrectomy, they can develop a cataract. So in the how long have I been in Eastbourne now? Nearly the 10 years that I've been a consultant, I've not sent one patient for vitrectomy. And I think I may have sent one patient for laser vitrectomy because they were very symptomatic. But most of the time, the kind of patients I see for floaters have good vision, perfect vision. When you really ask if it's stopping them doing what they like doing, the answer is often no. So vitrectomy is definitely out. And if the floater doesn't have the right characteristics, laser vitrectomy is out as well. Again, with those, I'm sure Cash would agree, you need to really counsel them properly, because you know, what you don't want is to break up one floater into lots of little floaters and then they come back at you. So you need to laser the right patient and know what they're expecting. But certainly for vitrectomy, I think you need to have poor vision, so 6 or worse. It's really causing them lots and lots of problems, and they're very keen to and understand the side effects of going for a vitrectomy.
Thank you, Shah. Next question. If a patient has sudden floaters, but dilated examination shows no holes or tears or an attachment, do we still refer?
No, I think if that, so you're looking at for things like, so for example, you're looking at the vitreous. So you're doing a dilated exam, obviously. You're looking at the vitreous for pigment cells. You're looking at vitreous for hemorrhage. I think if you have vitreous cells or hemorrhage, you should refer. If you don't have vitreous, hemorrhage or pigment cells, you can see a cause for the floater, i.e. you can see a posterior vitreous detachment, and you've done a good Volk examination with a superfield, which you can normally get right up to the aura with that, and you're confident with your examination with a superfield, and you've got a PVD which explains the symptoms. You don't need to, but you tell the patient if it gets worse or if you get a shadow or anything like that, you come back. Of course, you know, having a PVD doesn't mean you won't get a retinal tear. So I would say anyone with a floater, if there is vitreous hemorrhage or pigment in the vitreous, you must refer if you can't see a tear. If you can see a clear PVD and you've done a good dilated exam and you can't see anything else and you're comfortable with your examination, that's fine. You don't need to refer. I had a chat with one of my vitreoretinal colleagues about this, about doing a triple mirror and indents, etc. We don't expect that in the community because, you know, some of you obviously are not confident with the indent or a triple mirror. But I think, as I said, if you can see a PVD and there's no hemorrhage, there's no blood, there's no pigment cells, and you had a good look around with a superfield, then you're fine.
So thank you, Shah. So, but leading on from that, the next question, occasionally we see elderly patients with flash and floaters with significant peripheral posterior capsule opacification, which makes viewing the sort of peripheral retina very murky. Any tips on what to do with these patients?
No, and I think that's why I said that if you're not sure, then you should refer. So you know, what you're essentially saying is, look, you know, if I can't see an obvious cause for that floater because my view is not great, is it safe to say they're fine? And the answer is no, because if you're not happy with the view, then that person should be referred. And you have a very valid point. So if they have lens opacity or PCO, and that would prevent me having a look, then I'd need to think how I would address that. So I think the answer would be to refer, and then we can see if with an indirect we'll get a better view, or with a triple mirror we'll get a better view of the round of the eye. But if we can't, then that does pose a problem. So I mean, you know, if I've got somebody who's got a dense who's got a cataract and I can't see the back of the eye, I'd need to think how I deal with that. But yeah, from your point of view, if you're not happy with the view, then you should refer in somebody with an acute floater.
Lovely. Thank you. And the next question is, what's new in wet AMD treatments?
Okay, so is that from you, Ian?
I'm interested in this
I
one.
don't think I planted that one. So, so you know about Lucentis and Eylea. Avastin might be coming online. At the moment, we are not sure yet, and that's the whole legal issue that at the moment we can only treat patients with 612 to 696 vision. Please, please, please refer patients if the vision is better than that, because by the time they come to us, the vision may drop, or we need to just go through the options with the patient. However, if the Avastin becomes available on NHS, the commissioners might decide to lift the restriction. But I think what you might be getting at is the new drug called Beovu, which is a 3-monthly injection by Novartis. It's given 1 a month, and then after that, every 3 months. Now, that I think will probably be the case for 50% of the patients. The preliminary data suggests that Beovu might work 3-monthly for about half of your patients, but the other half might be 2-monthly. So it would be Lucentis, because at the moment we are seeing patients 6-weekly for that, although we should be seeing them 4-weekly. So that will give us a bit more breathing space. It hasn't had NICE approval. It's got EMA approval, and it's being used in states, as far as I know. But I don't think it'll be long before NICE approves it, and hopefully we'll be able to use that on our treatment-naive patients. It might also be quite useful for switch patients. Other treatment, radiotherapy has been hanging around for ages. I don't think there's anything new with that, to be honest. Stem cell therapy, again, nothing available commercially, although I think the next few years we'll see a lot of that. Drops, I mean, this would be a whole different lecture, so I'm just going to be quite quick about it. Drops, injections, and tablets are being looked at for dry AMD, even certain types of laser. Nothing that's kind of there just yet for dry AMD. There is a laser for dry AMD, again, that's been looked at by some trials, and they're recording some success. But from the wet AMD point of view, Beovu, which hopefully should be available this year, depending on when COVID allows us to get back to normality.
Thank you, Shah. Next question, is that purchase due to hyperlipidemia?
Yeah. Is that Mo? Yes, very good. Whoever got that right, that's purchase. And that's, you can get purchase from purchase retinopathy from pancreatitis or cardiothoracic compression from car crashes and things like that. So, and the answer is you leave it and it gets better on its own. But you get this very florid looking, if I just very quickly show you, this very florid looking, oh, let me see, I don't think it's allowing me, oh yeah. Florid looking reaction, look at massive cotton wool spots all around like that. Nothing gives you this really. It's almost pathognomonic of this condition in the right setting. Anyway, that's that. Yes, so it's purchased. Well done to whoever got that.
Thanks, Shah. And the next question, I think, is the last one. Is there any difference in the anti-VEGF injections patients receive if they are treated in the NHS versus the private sector?
No, I think so. I think the only reason one would go private would be that if they're insured, so the insurance company will cover them for 3 visits. For 3 visits. If they are self-pay and they have, they're within NICE guidance, they should go through NHS. I mean, there's no reason to go for private then. But actually, so very good question. Lucentis, Eylea, and Avastin give you the same visual outcome. You can expect to see just as well with treating patients Avastin, and majority of my private patients who come to me have Avastin because of self-funding, and it's a lot cheaper. Lucentis and Eylea are obviously the licensed product, but this is the crazy thing. So we've got a situation in this country where you've got 3 very good drugs. They all work pretty much the same, but you restrict the patients because of these kind of 612 to 696 guidance, but only allow them to have the more expensive licensed drug. What they should do is allow everybody to have Avastin. Those who don't respond to Avastin can then have Lucentis or Eylea, and they've saved loads of money. But that does open a whole can of worms with respect to research, use of licensed product, and using an off-licensed product just because it's cheaper and not because it's superior. So it's not inferior. So Avastin is not inferior to Lucentis and Eylea. It's just not better. And I think that's where it's becoming quite difficult, because you're, you know, as a clinician, when a patient is eligible to have an NHS treatment because they fall within those vision guidance, it's quite hard to say, well, have Avastin because you can save us money. So you will turn around and say, well, you're saying it works the same. Why not? And I think the answer is, if you look at a 2-year data, you know, when you compare an Avastin patient to an Eylea patient, the Eylea patient on average has 2 or 3 less injections. And that's where it's going to be difficult, because what you're then telling your NHS patients is, can you have Avastin so we can save money, but can you have more injections? And these are all the difficult conversations we need to have with our trust, CCG, etc., to see how we're going to proceed. Some of you may know that there was a legal battle between pharma and a couple of NHS trusts that wanted to use Avastin, and the judge has ruled we can offer patients Avastin on the NHS, but there was no mention about thresholds. There was no mention about the money that's saved. Who's going to get the money? Is it the CCG? Is it us? So there is a whole lot of things that we need to talk about. But in essence, the 3 drugs work the same. I think probably in patients with moderate to severe disease, Eylea might mean less injections, and I'm sure Buvio would do the same. That would be a conversation to have with the patient, because the commissioners cannot save money and therefore take away the threshold unless enough NHS patients go for Avastin, because that's the only way they're going to save money. And they've not been keen to support patients at an early stage, even if it means that they won't then need their more expensive drug. So it is a nightmare. It really is a nightmare. But you know, it's good to know that we have got an off-license drug that's very cheap, and it works the same as the expensive licensed products.
So do you see patients at the same intervals in private practice as we do in NHS?
Yeah, I mean, I think we can, I'm obviously not as busy as NHS clinics are, so I can probably offer them appointment every 4 weeks. NHS, they do 6 weeks, but we do have very clear criteria to say that if you think a patient should be seen sooner than 6 weeks, then you should follow them sooner than 6 weeks. So if an NHS patient is very active, and you know, you're seeing them every 6 weeks and you think actually 6 weeks is too long, then we have the means to see them at 4 weeks. So in general, if they're self-pay and they are within NICE criteria, then they'd be mad not to use NHS, because the cost will massively build up. At the moment, the only point to having it done privately would be if they're not within the NICE guidance, but hopefully we can reverse that by commissioners allowing us to treat this group of patients, which at the moment we haven't been, because when the 2008 NICE guidance came out, they put the vision threshold in, and these patients are kind of caught in the middle.
Brilliant. Thank you, Shah. And on the final point, any golden nugget take-home tips that you can give us?
Yeah, I think basically, you know, well, this will be available on YouTube. Ian will kindly do that. These are kind of like the emergencies. So I think what I would say is use the WhatsApp group if you're not sure. Me and Cash are always manning it, and you know, if you've got a patient that you're not sure about, you can ask us and we can let you know. I think main thing is to have a very I just want to kind of clarify, if you're worried about a patient, have a very low threshold for referral. It's always easier to have somebody who is slightly is more kind of cautious than somebody who's the other way and kind of too relaxed. But I think that's one of the nice things about the WhatsApp group, is that you can use that as a forum to ask, and you get a very quick answer to your question. And hope you're all safe, and we're all looking forward to opening up and returning to a bit of normality. Cataract surgery hopefully will start second week of July. It's going to be very slow, and hopefully we'll kind of plow through the backlog. And yeah, as I said, any questions, any problems, let us know. And I just wanted to say a final thanks to Ian for applying for CET points. He does all the hard work. I do the easy work, and for organizing everything. And he's really done a lot. So I just wanted to say thanks for that. And he probably wants to say thanks to somebody who's been helping me with the webinars, but I'll leave that to you, Ian. Thank you for logging in on such a lovely day. I'm sure you could have all been drinking in the park while, of course, socially distancing. Thanks a lot.
Thank you very much, Shah. Thank you very much for your time. And thank you everyone who has joined on the first webinar. I will be uploading CET points tomorrow. And the video will go on the YouTube channel in the next couple of days, but I'll let you know on the WhatsApp group when that is. And keep a look out on the WhatsApp group for the next webinar, and I'll be posting details of that shortly. But thank you very much again for watching. Stay safe, and we'll see you again on the next webinar. Bye for now.
Bye-bye.